Great. Well, thank you so much. My name is Danelvis Paredes. I'm one of the PGY3s today. I'm in charge of presenting an interesting case. I hope you guys enjoy it and learn a little bit as I did. So the story is, this is a 44-year-old male. He had significant history of very uncontrolled diabetes type 1, hypothyroidism as well. He presented with abnormal facial movements, headache, slurred speech, and left facial droop. So the story dated 2 weeks prior to actually his initial presentation. So this gentleman started having this left facial twitching. They will last 45 seconds to a minute. He remember wanting to talk, but really unable to. And this will follow by 1 to 2 minutes of confusion. However, these were happening very rarely, so he didn't give much thought and continue with his life. Now, 2 days prior to presentation, he developed this severe headache. This was unusual for him because he didn't used to get headaches. They were described as bifrontal. And he also noticed that the left corner of his mouth was droopy and his speech was really not his actual speech. It sounded more slurred. In terms of his physical exam, he did have, from the cranial nerve standpoint, he had a clear left facial droop. His speech was mildly dysarthric. From the motor standpoint, he was actually pretty strong almost throughout, except for a potential left upper extremity weakness 4+ to 5-. Sensory was pretty good. It was intact. His reflexes were 2+ throughout, or remarkable, and his gait was intact. So this patient actually presented from an outside hospital. Given his focal deficits, he was stroke coded over there. He had a CT scan done and a CTA, and he was ultimately transferred to the Duke Stroke Service for further workup. So the stroke service, very smartly so, they obtained a brain MRI with and without contrast. Here you guys can see this is a T1 sequence. There's a T1 hyperintense lesion on the what we call the right putamen. Just looking at this MRI, if you think about this imaging, something that comes to your mind is diabetic stereotopathy. However, this presentation clinically will be essentially, it tends to present with hemichorea, hemibolism. That's one thing. Secondly, it tends to present more on diabetic type 2 patients, not as of diabetic type 1. And it tends to be a presentation of elderly, none of which really fits with the presentation on this patient. Now, if we add some contrast to it, you can see in the T1 plus contrast, it's very subtle, but it's there. You can see potential right subinsular enhancement, and also some patchy enhancement on the bilateral basal ganglia regions as well. On the ADC, it's hard to see it here potentially, but he had hypointense right temporal with extension to the right parietal region as well. This you can see in seizures from cytotoxic edema. So with this presentation and these findings, enhancement, now more than a stroke, you're actually thinking of an inflammatory process. However, the patient, the good thing is that he was stable. He really wanted to go home. So the patient ended up being discharged with the plan to do an LP outpatient and a repeat brain MRI with and without contrast as well, outpatient. However, patient unfortunately came back just few days afterwards with very frequent seizures and an altered mental status. So he is readmitted now to the general service. So this is how I actually learned and got interested about this case, because I was acting as the EEG fellow. So I was reading this patient's EEG. You can see here on his EEG, he does have this very nice little right hemisphere rhythmic delta activity, more significant on the frontotemporal region. It had evolution. It did not spread to the left hemisphere. They will actually last 4 to 5 minutes. and then happening frequency of 1 to 2 hours. So essentially, he was in subclinical status. So as you can imagine, now a patient in subclinical status with enhancement on MRI, this patient needs an LP. And this what it was done. And unfortunately, it was really not exciting. So as you can see, there's no signs of inflammation. Nucleated cells were 0, protein was normal. The autoimmune panel was collected, as well as the encephalopathy autoimmune panel too. However, as you guys know, these tend to take time. So just kind of like reviewing like the patient presentation. As you can see, this was like technically like a subacute presentation, initially some focal deficit, seizures from time to time, now really rapidly decompensating, essentially being a status and altered mental status in the setting of that made the primary team very concerned, and they actually started empirically treated with IVIG. Now, after several days, boom, the autoimmune panel came back. The encephalopathy panel came back positive for GAD65, almost in the 5,000 range. The autoimmune panel from the CSF came positive as well, 28.7. As you guys know, GAD65 is elevated on diabetic patients. However, not to this extent. So with the clinical picture on the patient presentation, and now with these results, the primary team was pretty confident and that this was a presentation of GAD65 autoimmune encephalitis. So I will just expand the next 2 slides just to review a little bit of what GAD65 autoimmune encephalitis is. Essentially, what GAD65 is, this is a glutamate decarboxylase, so it's an enzyme. And what it does is that essentially it produces the GABA, and the way that it does, or synthesize GABA, the way that it does is like changing, transforming from glutamic acid or glutamate or glutamic acid to GABA. GABA is released through the vesicle to the postsynaptic neurons. So as you can imagine, if you have an antibody that is really impairing or blocking GAD65 enzyme, the GABA is not going to be synthesized, and consequently, what you're going to have is a constant central nervous system excitatory state. And that's why you tend to, the clinical presentation of this patient is like, as what we saw in this patient, refractory seizures, very, very, very hard to control. Epilepsy, this patient was on 5 different AEDs and was still seizing. Another clinical presentation that you guys might have encountered in the past is a stiff person syndrome, cerebellar ataxia, limbic encephalitis. This is not these are the most common clinical presentation, but it's not bound only to this. In terms of the age range, though, very young population, 17 years old to 50 years old. Ours was in that range. She was 44. Interesting, there's also a particular association to diabetes type 1, and thyroid disease. Our patient was unlucky enough that he had both. There's also an association with malignancy, and there's 2 particular malignancies associated to this autoimmune condition. One is a small cell lung cancer, and the second one is malignant thymoma. So we have to make sure that when we make this diagnosis, this patient is our screen for these type of malignancies. The other interesting fact is that the majority of these cases are monophasic, which means it happened once. It's not expected to flare or to continue to progress if after it's treated. So in terms of treatment, from the acute treatment standpoint, IVIG, as what was done with this patient, methylpred is also another option. In the long-term therapy has been considered. Cellcept is one, rituximab, and then basiliximab. However, is really not as famous or as common because, again, as I mentioned earlier, it tends to be, or the majority of the cases are monophasic. So the benefit from this long-term therapy is really unclear. Now, our patient course, he got 5 treatments of IVIG. On the day 3 session of IVIG, his seizures actually improved. He was down from 5 AEDs to 2 AEDs. They completely subsided. Unfortunately, the course was complicated by an aspiration pneumonia. Patient was very hard to extubate and had to be trached. He continued with these left-sided deficits that did not improve. And currently, the goal is to rehabilitate him as much as possible with PT, OT, speech. He should be seeing outpatient, the epilepsy team, and also the autoimmune team as well.
All right, thank you, Danelvis. So very nice. Wayne, will you introduce our grand round speaker, please? Wayne must be on mute.
Can you guys hear me okay?
Now we hear you. Yeah.
Oh, okay. I think something wrong with the speaker. So good morning. Welcome to the Grand Rounds. As you probably know, Duke is participating as a hosting site for the CTSA Visiting Professional Program for the KL2 scholars. So this program basically gave opportunity for the KL2 scholars to give grand rounds at a partner institution and meet with the faculty in that institution with the goal to enhance the scholar's opportunity to present their science and research work. Also give them opportunity to network and also create opportunity and for collaborations. So that's how I was introduced and I got a chance to know Dr. Michelle Lin. Actually, she and I actually gonna have one-on-one meetings this afternoon. Dr. Lin completed an undergraduate degree in biochemistry in Wellesley College in Boston. And then she went to the West Coast and had a medical school in University of Washington in Seattle. Then she stayed in the West Coast, did a neurology residency at the University of Southern California. And then he returned to the East Coast, did a fellowship at Hopkins. And after training, she actually went to the Southeast, took a faculty position at Mayo Clinic, Jacksonville. She currently is a KL2 scholar at a Mayo Clinic. Her KL2 project is retina, is a biomarker for cerebral small vessel disease progression. So with this, her talk today is a silent infection in a cerebral small vessel disease, the tip of the iceberg. I completely agree with this. I can't wait to hear the talk. So welcome, Michelle.
Well, thank you so much, Dr. Finn and Dr. O'Brien, for hosting me. It is my absolute pleasure to be here, and I'm really looking forward to meeting with several of you this afternoon. So let me share my slide. Are you guys be able to see my slide?
Yep.
Yes.
Perfect, thank you. All right, so today I'd like to talk about the silent cerebral vascular disease, which is the motivation to my current KL2 project, using the retina as a biomarker for early detection for small vessel disease, and hopefully to use as a biomarker for intervention trials in the future. So the pertinent disclosure is that the background of this work is really funded through this KL2 program, which has been instrumental in me understanding the science and be able to implement the proposed project. So here's the outline of the talk. I'll start by defining what the silent cerebral vascular disease is, focusing on the three cardinal types, which is the white matter disease or white matter hyperintensity, cerebral microbleeds, and silent infarcts, and the prevalence and the outcomes associated with cerebral vascular disease, and diagnostic evaluation and the treatments. So what is silent cerebrovascular disease? It is the most common incidental abnormal findings on the brain MRI, and it is more common than say meningioma or and other findings combined. And it does not have overt clinical stroke symptoms. However, it doesn't mean that the patient has no symptoms, but those symptoms tend to be more, slower, insinuous, and it would include a subtle gait dysfunction, cognitive decline, mood, apathy, and increased disability in this population, and is highly associated with clinical stroke, intracranial hemorrhage, and dementia. Here's a nice schema that cartoon that described on the right side. Here's the ischemic side. So there's the lacunar infarct, and there's the white matter hyperintensity in large perivascular space. All of these are small vessel disease subtypes. And on the hemorrhage side, that there's the deep microhemorrhages, perhaps from hypertension, and the low bar microbleeds from the CAA, superficial siderosis. And why does it matter? In part because, for every symptomatic stroke, which we usually quote that is about 7 to 8 million, in the US, that there are 10 silent brain infarcts, and that would translate to 70 millions, and that is about 25% of the US populations. And corroborate of the epidemiologic study showed that 1 in 4 people above the age of 80 would have at least 1 or more brain infarcts that are silent. And I wonder, can the same stroke prevention measurements, which we have a lot, that can be applied to this patient with silent cerebrovascular disease, and in a way that the clinical stroke or hemorrhage is really just the tip of the iceberg, and there's a lot beneath, and I like to take a deeper dive on it. So here are the condonal types. There's the white matter disease, which is extremely prevalent, especially above the age of 75. So it's about 90% of them. But the way I think about it, if 90 or all of the people above the age of 90 would have white matter disease, that's not really a disease. So it's really kind of unclear at this point the threshold in which normal aging crosses the threshold and becomes disease. And in the current literature, they loosely define moderate to severe white matter disease as the pathologic, and that the prevalence of that is about 25%. And there's the silent infarct. There are 2 types, like stroke. And so there's the lacunar stroke. There's the lobar infarct. So the majority of the silent infarct, or 80%, are lacunar, while 20% or less are non-lacunar, can be embolic or other etiology. And again, the 20% of healthy elderlies would have, this silent infarcts. And finally, there's a cerebral microbleeds. It's fairly common. So it's 5 to 20% of general population. And for those above the age of 80, it's about 40%. Of those who technically, meet the criteria for probable CAA, or cerebral amyloid angiopathy. To standardize, how to report the small vessel disease findings. So back in 2013, there's the STRIVE consortium, led by Dr. Johanna Warlord in the University of Edinburgh. She came up with this standardization of the reporting that many of you are familiar with, that there's the white matter disease on the MR flare or T2. It's just it's variable in shape, and it's appeared bright on flare, and there's lacunar, chronic lacunar, size between 3 to 15 millimeters. millimeters in size. Then finally, there's the cerebral microbleed, is less than 10 millimeters in size on GRE, T2 stars, or SWI, or SWAN, or others susceptibility sequences. And the first phenotype is the white matter disease of the presumed vascular origin. So it goes by many different names, and there's the leukoarteriosis, chronic microvascular ischemia, and small vessel disease that used loosely to describe white matter disease. And on the head CT, hypodense lesions, and on the MRI flare, that it will be there's subcortical, punctate, or confluent lesions, and there's the periventricular confluent white matter hyperintensities, and T1 it would appear as hypointense, as demonstrated here for both subcortical and periventricular. And Fazika scores the most commonly used semi-quantitative measurements for different locations of white matter disease. And there's the periventricular from 0 to 3. There's the 0 is absent, and 3 is the confluent and contiguous into the deep portion, which is a subcortical portion. And again, 0 to 3. So white matter disease prevalence increases by age. And here's a very nice natural history data in which that, in the younger patients, below at the age of 55, is much less common. So the pathophysiology and the disease really starts in our 40s or so, and but by the above 75 years of age is really quite prevalent, as previously quoted, as of 90% or more. And white matter disease is associated with stroke, both ischemic as well as hemorrhagic or intracranial hemorrhage. And is tightly associated with dementia, vascular dementia, or for the CAA type, and be Alzheimer's dementia. And there will be some gait and balance disturbance, and mood, depression, apathy. So here are the numbers to back up that figure. So here's a meta-analysis of nearly 100 longitudinal study involving about 15,000 patients, and with the outcome of white matter of a stroke, ischemic stroke, hemorrhage, dementia, Alzheimer's, and death. They look into the patient with extensive white matter disease, and the hazard ratio for stroke is about 2.5. For hemorrhage, it's about 3.2. And there's a dose dependency to the severity of the white matter. So here are various outcomes: dementia, any functional impairment, all-cause mortality, and also recurrent stroke. And on the x-axis is the severity of white matter disease using the Fazika score, and there's the probability of having the outcomes. And here you see that there's linear projections to most of the outcome from this meta-analysis involving about 71,000 patients. Now, the question is that, so this is, a makeup patient, but we see this type of patients all the time. So it's a 40-year-old coming to our clinic, and there's not a trace of white matter disease. And we see another patient, 90-year-old, otherwise quite healthy, no vascular risk factors, and is 90-year-old. Now, is this normal aging or is it pathologic? So I would venture that it is, pathologic, in part because it is considered as Fazika, 3, because of the confluence in the subcortical, and also 3 in the periventricular as well. And what are the predictors of high white matter disease burden? Again, the prevalence is between about 20 and 19 to 33, and it's really a combination of genetic, age and modifiable risk factors, and neurovascular unit is key when it comes to small vessel disease and white matter disease, and a combination of three factors, leading to neurovascular decoupling and ultimately cognitive impairments. I was pretty upset when I kind of dive into the literature and says that the traditional risk factors only explains up to 2% of white matter disease variants. So, and unfortunately, the majority of them are genetic or driven, such as, there's the classic CADA-cell, the NOTCH3 mutation is highly inheritable and penetrable. This is the monogenetic disease. And the CWAS study, there has been quite a number of CWAS done, and at least about 13 genetic variants has been identified. So who knows, maybe in the future, gene therapy is on the horizon. And hypertension, the risk factors, and here's the pathomechanism that leading to it. There's some kind of some people kind of hypothesize maybe inflammatory, demyelinating can be hypoxic, or just blood-brain blood barrier breakdown, and but there's hope. So we can treat vascular risk factors, and there's good data in support of that. The control, the intensive blood pressure control can slow down the progression of white matter disease. So SPRING trial is the landmark trial published in New England Journal in 2015, involving adults 50 or older of the age with hypertension and at least one risk factors from 2010 and 13, then randomized the patient to intensive blood pressure control to goal of less than 120, and it's just the other group is just 140, 1-to-1 randomization. So nearly 9,000 patients participated, and there's the risk reduction of stroke, heart attack, death by about 25% reduction. And the ancillary study that came out of the post hoc analysis from the same study, involves about 670 patients with baseline MRI and follow-up MRI with a primary outcome of white matter disease volume, and with a median follow-up of nearly 4 years. And they found a significant group difference about 0.54 cc's of white matter disease volume progression. So the intensive blood pressure target of 120 or less would slow down the progression of white matter disease per SPRING MIND trial. It's published in JAMA 2019. So moving on to cerebral microbleeds. So this is how it looks like on the susceptibility sequences. Know that SWI is more sensitive, so by about 2 to 3 folds compared to T2 stars. So we're picking up more and more of the microbleeds because of the imaging technology becoming more advanced. So here's the hypertensive microbleed in the deep structures, basal ganglia, and brainstem, and there's the lobar bleeds and tend to be cerebral amyloid angiopathy using the modified Boston criteria. And here's a population study using the Mayo Clinic study of aging, enrolled 1,200 patients, and the prevalence of patients who live in the Homestead County, Minnesota, and the prevalence in the general population is 5 to 21%. And among those who had suffered from incident in the ischemic strokes about 30 to 40%, and hemorrhage is 60 to 70% of those who has cerebral microbleed. And here is another population study from Iceland. Enroll patients is a population study 66 to 93 without baseline dementia and has at least 2 serial MRI with the mean follow-up years of 5 years. And they found that the incident microbleeds is about 18%, and among those, who has the bleeds, so they found that having a diabetes, underweight, being a smoker, and heavy alcohol drinking and elevated blood pressures are associated with cerebral microbleed as risk factors. And the cerebral microbleed is associated with increased future risk of incident hemorrhage. And here's the data, population stroke 2015. It's a meta-analysis with a total of about 3,000 patients with cerebral microbleeds. And the authors found that for those with microbleeds, that the risk of intraparenchymal hemorrhage is about 8.52 odds ratio, and finally the ischemic stroke is about 1.6. What about silent infarct? Shifting gear again, and here's the majority of the silent infarcts are again subcorticals, 90%, mostly lacunar, and for decortical is about 10%. The prevalence of the silent infarcts using this systematic review of 105 patient studies, and 8 of those studies are population-based studies, as kind of summarized here in this table. So the prevalence kind of range between 8 to 28. So I want to kind of bring your attention that the mean age between the one with the lowest prevalence is the 64, and those with the highest prevalence in this cardinal population study, the cardiovascular health study, is the 75. So age plays an important role in silent infarcts. And this is graphical description of how the prevalence of silent infarcts increases with age, and 20% is sort of the number that are commonly quoted. Just in healthy and elderly, and they define that as the age of 70. From the SIM study, that they found that the prevalence of silent infarct increases, with baseline systemic diseases or cardiovascular diseases. For instance, for those with atrial fibrillation, the prevalence of silent infarcts is about 32. And dear to my heart is that those with asymptomatic carotid stenosis is the silent infarcts about 23. And interestingly, those with diabetes and chronic renal disease, is really quite high. For the chronic renal disease is 51%. So it's about half of the patient with CKD would have silent infarcts. So it's a fairly old study from 2007, but unfortunately, this is still yet one of the better studies out there that reported the prevalence of silent infarcts. And from the population level, that the study showed that there's a higher incident clinical stroke among those with silent infarct. Here is again the cerebral vascular health disease study. So the incident, the prevalence of silent infarcts is about 28%, and they found that those with silent infarct are more likely, that have the risk of a stroke is about 1.8 per year of their risk compared to those without silent infarct, and add up to the hazard ratio of 1.5. And Rotterdam study, the hazard ratio is up to 3.3. So silent infarct is maybe a biologic markers, for future risks of incident and clinical stroke. And pulling the current data together, and in this meta-analysis that involved 13 studies and a total of about 15,000 patients, and they reported that there's the relative risk of nearly 3 for incident stroke in those with silent infarct. So 3-fold increased in stroke. So that, to me, as a stroke neurologist, is opportunity. So does it make sense for us to treat the silent infarct like how we treat the true stroke, clinical stroke? So I conceptualized the silent infarct according to the TOAST criteria, and so the causes it's always just cardioembolic, large vessel. So for cardioembolic, there's the heart failure or atrial fibrillation leading to a global hypoperfusion of the stroke and of the brain, and there's the either hypoperfusive or artery to artery thrombosis of the large vessel atherosclerotic disease leading to silent infarct. And of course, again, the 90% of silent infarcts are driven by small vessel disease and the microvascular. And here are some simple pictures of the lacunar stroke. Deep structures, and now we can recognize the lacunar in acute setting just fine, but over time that the lacune, the changes in its appearance on the follow-up MR, some of the lacune disappears, and so this is a nice study. So this is acute, there's DWI flare, and 1 year later 10% of lacune kind of disappear. You can barely see it 1 year later, and some lacunes over time just becomes and look like white matter disease. And finally, that the way that the way we to really kind of identify lacune is really this cavitation is about 20 to 94%. That's a huge range. So the guideline, what does the guideline say? Just earlier, several months ago, finally the 2021 secondary stroke prevention guideline came out. It says that those with non-cardiac embolic stroke, they need to be on some sort of antiplatelet agent. And unfortunately, how we treat lacunar small vessel disease stroke is really quite limited. And this is an old study by now from 2012, but still one of the randomized clinical trial, the only one right now, really, and they compare, the recurrent stroke risk in patients who presented with the acute lacunar stroke, and randomized to dual hypotherapy with Plavix and aspirin versus aspirin, and found that there's no difference between dual hypotherapy versus just aspirin alone. Yet that dual hypotherapy is associated with increased risk of all major hemorrhage. So we also know this, from the much more recent studies, but not specific to small vessel disease, such as the CHANCE trial and the POINT trial. Which is consistent with the recent trials. So is there anything emerging to treat this small vessel disease infarct? So cilostazol is an emerging therapy. So, but the level of evidence is just 2B. So it is there's just not sufficient data to support the usefulness of this, so it's uncertain. So solestazole, what is that? So that is a phosphodiesterase, inhibitor. It's a selective one. It decreases the CAMD and therefore lead to antiplatelet function, and it dilates the smooth muscles, and it has some kind of anti-metabolism functions as well. So the LDL actually goes down a little bit, when the patient's on solestazole. Of note, solestazole has been FDA approved for peripheral arterial disease, ever since the 1990s. This CSPS2 trial it's a Japanese study, enroll about 3,000 patients for non-cardioembolic infarct and randomized the patient to solestazole versus aspirin, and with a primary outcome of stroke. And the study showed that there is a significant 26% risk reduction for future risk of stroke, among those who took the solestazole group. And the most exciting finding is perhaps the safety outcome. So, doing hypotherapy, Plavix, aspirin increase the risk of, hemorrhage, but solestazole actually decreased the risk of hemorrhage with a hazard ratio of 0.5 for hemorrhagic events, as described here in this study. And we did a meta-analysis on the existing randomized clinical trial, and there are about 7,000 patients. So the risk of recurrent ischemic stroke is about 0.7, the risk ratio, and for hemorrhage is 0.41. So the conclusion to that is the solestazole lowers the risk of recurrent stroke, and but it has lower bleeding risk compared to other antiplatelet therapy. What about the large vessel occlusive disease as the etiology of silent infarct or stroke? So we know how to treat high-grade carotid stenosis that's symptomatic really well. You just do revascularizations, surgery and stent or endarterectomy, and there are emerging data that really we need to treat the unstable plaque as well, but we don't know much about the asymptomatic carotid stenosis group, and we know that the prevalence of silent stroke is about 25% among the group, and it's associated with cognitive decline. But the way that we can, but how do we identify the high risk patients with silent infarct to really do the revascularization therapy? So TDC, or transcranial Doppler emboli detection, or plaque imaging, or cerebral vascular reserve imaging are the three modalities that that can help identify the higher risk group. So the microembolism detected by the TCD predicts future stroke. That is so now a pretty old study led by Dr. Marcus. So it's an observational study. They took patients with asymptomatic high-grade carotid stenosis and did TCD at various time points, and the primary outcome is the ipsilateral stroke. And they found that for those with positive microemboli detected on TCD, they're at 2.5, increased hazard risk of having TIA or stroke, or 5.6 increased risk of ipsilateral stroke. So this is definitely a high risk population if they're tested positive on TCD emboli detection. And the plaque stability is also another biomarker. So here's the low resolution visual image. Like we can see that right here, this is a normal plaque, also has a nice lipid structure and nice healthy fibrous cap. So as we have shown that if you have intra-plaque hemorrhage, one would have higher risk of stroke. And unfortunately, there's no randomized clinical trial that has looked into this yet. And there's the cerebrovascular imaging, and this is the imaging that I use for my KL2 pilot clinical trial. So what is cerebrovascular reserve image? And it is basically to capture the blood vessels' ability to dilate in response to physiologic changes such as stroke. You need to have the cerebral blood flow imaging, either through cranial Doppler, transcranial Doppler, or ASL on MRI, or the MRI bold image. And you need to have the vasoactive stimulus, and most centers use breath hold and acetylcholinezolamide is something that can be used. Inhalation of 5% CO2 is another method. And right here we use the Respiract, which that we can quantitatively measure the person's entitled CO2 and match that to cerebral, the bold signal on the MRI bold functional MR. And here's the science behind it. So here's an example patient, one with asymptomatic carotid stenosis on the left, and the patient is put through the cerebral vascular reserve image with the Respiract CO2 challenge. And you see that the warmer the color implies the good blood flow and intact cerebral vascular reactivity. And this patient one, has intact cerebral vascular reactivity, and patient two, alternatively, on the other hand, also has high-grade carotid stenosis, but has impaired cerebral vascular reserve as indicated in blue. In fact, this patient has steal phenomenon. The good side is stealing the blood because of the maximal vasodilation, so steals blood from the affected side. And the meta-analysis done by Reinhardt et al., published in Neurology, basically show that those with impaired vascular reserve, or this red line here, are at a 3.7 increased risk of having incident stroke in those with asymptomatic carotid stenosis. So again, cerebral vascular reserve is another the markers to identify high risk patients for stroke from those with asymptomatic carotid disease. And cognition is really becoming more and more of an interest in all kinds of stroke trials. So the impaired, so this is a study that published in Neurology a while back now, that they used the collected patients with right-sided carotid stenosis, and this is the complex figure copy test, and clearly that those with impaired vascular reserve, have a score lower on the testing. Here that there's this multi-center study. The CRUST-2 is led by the group here, Dr. Tom Broad and Dr. Maskia, and Dr. Lyle is the vascular surgeons, and these two are vascular neurologists. And they're leading in completing the CRUST-2 trial. I know that Duke is also a site to this multi-center trial. There are, I think that the trial is really, they're at, I think, 75% to completion. And the CRUST-H uses that cerebral vascular reserve concept, is led by Dr. Marshall at Columbia, and here are the co-investigators. So how do we take care of patients with this silent cerebrovascular disease? And thankfully that there's a guideline, specific for it, published in 2017. So it's about 5 years old now. And I hope that there will be a new guideline coming up. So the diagnostic evaluation for silent cerebrovascular disease, and so a good history is important. So just assess common vascular risk factors and feel the pulse just to detect atrial fibrillation, and consider carotid imaging if the patient on the MRI shows that there is some asymmetry, to the white matter disease burden or infarct burden that are silent. And consider echocardiogram if there seems to be some embolic appearing infarcts, and angiogram if the patient has the cerebral microbleeds, just to rule out mimics such as cavernoma or traumatic brain injury for those with cerebral microbleeds. And how do we prevent silent infarct? And again, getting a good history physical is always, a good starting point. So I just want to make sure that the infarct is not that not symptomatic, because the treatment is going to be quite different. So primary the prevention of stroke, applies, and the effectiveness of aspirin to prevent stroke has not been studied in this setting. And there are, we know that the recent news is that without any indication, we really shouldn't put the elderly on aspirin because of increased risk of, bleeding and death. So this is an important point. And finally, that it is reasonable to consider, interventions, such as anticoagulation, revascularization, statin for select patient. And there really needs to be clinical trials that study this. So in summary, that silent infarct and silent cerebrovascular disease is very common, and is tightly associated with risk of stroke and dementia. And we really have a fantastic therapy on the acute setting and also preventative setting, both medical and surgical, to prevent, to treat stroke. And does it make sense, to apply it to silent stroke? And unfortunately, that at this point, the guideline does not recommend screening MRI. It is not justified from economic standpoint. So I wonder, maybe one day the MRI will cost less, or maybe we have sufficient data, to support the population screening to prevent stroke. But at this point, screening MRI is not indicated, and intervention trials are desperately needed, in this population. So I'm going to end with this summary slide that we see stroke 7 million, but silent stroke is 10 times higher. There are quite a number. So I want to thank the KL2, and this is all of the mentoring teams behind the scene. And I thank you for your attention. I'll take any question.
Thank you. Thank you so much for that talk. I'll make a comment, and this is more of a peccadillo of mine. I still remain stunned by the fact that white matter disease is referred to as ischemic, in spite of all the data that suggest it's related to neurodegeneration as well. Yet everyone thinks it's ischemic, vascular. Well, it's at least every radiologist in the world. Is there any way we can change their minds?
I really wish that they would. Thank you so much for the comment, Dr. O'Brien, and I completely agree with you. And I've seen so many patients with really head full of white matter disease, yet the radiology reports say microvascular ischemia, as if that it is stroke, yet that they're at a higher risk of hemorrhage. if they're put on too rigorous of the antithrombotic therapy. I do think that there needs to be a lot of work on, working with our radiology partners to really kind of be cautious about the wording that they put on the radiology report to avoid the term of ischemia. And maybe just
Kelly, you're now my favorite vascular neurologist. Thank you.
All right, so I see that there's a question from Hillary Yu. So how about migraine? Some study reported migraine with aura with increased risk of white matter, over 68%. Is that the direct reason for migraine? Patient has increased risk of stroke, and should we do silent stroke prevention for those population? Very fantastic question. It's interesting that you brought up migraine. Things like RCBS, coming with horrible headache, or and we classically kind of see those subcortical white matter punctate lesions are very commonly seen in our migraineurs. But the classic the carousel is the disease that I'm studying. And that has a triad of migraine, stroke, and dementia. We do think it's likely from the disease of the smooth muscle, perhaps, and the endothelium, the Notch3, and all of those would impair the cerebral vascular reserve. I do think that it is related. And of course that there's the PFO, is also pretty common in the migraine population as well. Right, so they're definitely interrelated. Yep.
So Michelle, I have a question. So great talk, really learn a lot about cerebral and small vessel disease. One of the slides you mentioned, about a 10% lacunar influx will be disappeared on the imaging. So a little bit skeptic about this, because once the lesion shows on the T2 flare, they are hard to disappear. Just wanted to study, I use dedicated research imaging, or just compare with just, clinical scan. Sometimes, different sequence, different cuts, and sometimes those lacunes very easy just lost it, in between. And then we label it as disappear, but actually they don't really disappear at all.
I completely agree. So I think that study was done back in 2013 or so. And since that, the MR, the magnet strength has improved, the 7T and even more higher magnet strength. I do also agree that it is just because we can't see it, it doesn't mean that it is not there. And secondarily, that there's the similar to Wallerian degeneration. So the cortical thickness, really kind of thins over time, while that on the, the flare lesion, that classic lacune, may have disappeared, but maybe that there will be a global, cortical atrophy, from that disappearance of the lacune. Same thing as well for white matter disease, and people think that the white matter disease disappeared, but perhaps it disappeared because the entire brain is shrinking. So it's complicated. We're really at a really exciting time, to have all kinds of advanced imaging and the AI machine learning to really try to incorporate all of this, multiple variables that we cannot really detect with our eyes. Very good point.
Michelle, I have another question. This is another one of my things. Dilated perivascular spaces, called lacunar strokes. And the idea that a little bit of flare signal on the edge separates an old lacune from just a dilated perivascular space. Do you have a comment on that?
Yeah, that is a good point. And if I kind of go back to, the Strive consortium that they defined lagoon as between 3 to 15. So I think anything below 3 millimeters in size will be considered as enlarged perivascular
But
space.
you know that perivascular spaces can get big too.
Oh yeah. So I when I'm doing the a lot of the gradings of lagoon or enlarged perivascular space, and especially those with carousel, I was like, should I call this lagoon or should I call this just really enlarged perivascular space? Absolutely, but there is some guideline about it, the 3 millimeters, but who actually measures it out?
Exactly. And who came up with the p-value? It's all arbitrary, right? And we really don't know.
Absolutely.
Anyway, thank you so much for your talk and your research. I think it's very, very important. And don't be afraid to consider yourself a dementiaologist as well as a vascular doc.
Right.
Welcome to the team.
Well, yes, I do. Just like Aricept, I do prescribe Aricept, just like but aspirin is still my favorite.
You could make a combo, Aricept and aspirin.
Right.
Marvin asked a question which goes to that. He said, does an asymptomatic 80-year-old patient with only microvascular disease need to take daily low-dose aspirin? And I was thinking it's more likely they need to take donepezil than aspirin.
Agree. So at this point, I would not advise my patient with just purely white matter disease without any indications such as concurrent coronary artery disease or a lot of atherosclerosis in the carotid, to subject them on an aspirin. We know that, it's associated with death and hemorrhage for primary prevention. So we do not use aspirin for primary stroke prevention unless the patient has risk factors to justify it.
And Michelle, you must know Rebecca Gottesman, but Rebecca is now a full-time dementia doc, and she's a vascular neurologist.
Yeah, so I know Rebecca well. She was my mentor when I was at Hopkins, and
that's right. I forgot. Yeah.
Yeah, so right, I learned incredibly a lot from Rebecca, and also the whole thing about the small vessel disease, and she also spearheaded a lot about the cardiac and brain connections, on heart failures, and she led the ERIC. So that's kind of one of the reasons why my talk is so heavy on epidemiology, and that's just Rebecca's influence, absolutely.
Wonderful.
Hey, Michelle, was just probably the last question. So our stroke group, I kind of expect you talk about a little about retina is the way to monitor the cerebral and small vessel disease. Maybe I missed that you didn't talk about. Maybe you can just spend a few minutes. What part of retina you look at, what kind of parameter you use in trying to monitor the progression of small vessel disease.
Right. So yes, my KL2 study really is trying to identify retinal biomarkers that would differentiate different small vessel disease subtype. So the three groups that we look for, in my, the clinical trials, the pilot study supported by the KL2, we study patient with carousel, cerebral microbleed or CAA, and finally just pure white matter disease and in healthy control. And we randomize these patients to celestazole versus just no medications. And the retinal, retina is one of the markers I look for. So, so the patient come at baseline, I randomize the patient 1-to-1 and follow them at 12 months. And I'm starting to see them for coming back. So they get a retinal scan, they get a cognitive evaluation, blood work, and MR battery with the vasoreactivity. The OCT angiography or optical coherence tomography is the one that I used. We used, OptiView is the company that I used, in which that they have this software to basically populate, give me this automated measurement of the retinal thickness by inner and outer retina and the choroid process, and also they have the vessel density. Which is really nice because those are micro vessels that we can see on the typical angiogram. So those are the outcome measures or that I look for from the retinal standpoint. And of course, population studies such as ERIC, that was kind of led by the Rebecca Gottesman, is that they use the fundoscopic photos and have seen that but if you have say AV nicking or microaneurysm or flame-shaped hemorrhages, all of those retinopathies is associated with future risk of stroke and dementia, and specifically lacunar stroke as well.
And Michelle, I don't mean to complicate your work, but do you know of Sharon Feckrat's work? Fekrat. She's a Duke ophthalmologist, and she studies how retinal blood vessels change with Alzheimer's disease. So you've got, you've got it, of course it changes with vascular, but it also changes with neurodegenerate. So you've got it just complicates it is all I'm saying.
Absolutely. So I feel like the OCT, the retina is likely going to be translated to all sorts of neurological disease. And I think that MS, multiple sclerosis, they have used the retina as a marker for intervention trials. So I think that the layer will be kind of thinner, and they select that as sort of the early markers and kind of randomized that. So I envision that to in neurodegenerative disease trials in the future, and of course in small vessel disease of the brain, absolutely. And dementia group, they definitely are looking into different retinal features.
Thank you.
All right, looks like we're way over time, but it was a very exciting, and we look forward to your career development. And I think the more stroke doctors interested in cognitive changes, the better the field will be too.
Absolutely.
Yeah, thanks, Michelle. Looking forward to meet you this afternoon. Yeah.
Great. Thank you so much.
Bye, everybody. Stay safe.
Bye-bye.